Thing we look at then from adrenals include the infections, which very often are viral infections. Okay, so when we look at infections, especially the infections that have no respecters of boundaries, we're looking for the infections that are the GI infections, so parasites, and more importantly, in these types of syndromes, we're looking for the viruses, Epstein-Barr virus, cytomegalovirus, the chronic viruses. And then, one of the worst guys of all are the spirochetes, the bacterial infections that have no respecters of boundaries. Okay, the spirochetes are the causers of Lyme disease, the Borrelia burgdorferi. But then we also look at the one that causes the infections in the upper GI system in the stomach, causing ulcers, which is Helicobacter pylori, which now, according to Dr. Nordquist out of San Diego, a dentist, he's actually showing that that same spirochete is in oral pathology. He's showing that in the microscope. And again, that same spirochete family is the same disease called syphilis. Okay? Syphilis is the disease that the sailors used to get, and it's a sexually transmitted disease. The interesting thing of it was the mnemonic to remember it was I can't see, I can't pee, and you can't dance with me. Okay? Because they actually would have painful ulcers, they would have loss of eyesight, and then they have sores that would disallow them to void their urine. So when we look at those spirochetes, you can see how it doesn't respect any boundary and it goes across all of those tissues. Well, can't see, can't pee, can't dance with me, that sounds a lot like some of the people who have Lyme disease. I can't move anymore because I have such pain. I can't see clearly because my brain is so distorted that my visual perception, my distortion or focus and mental acuity is diminished, and those spirochetes are very, very, very deleterious in their effects of the entire system. It's not just, oh yeah, I had Lyme disease, that tick bite was bad. Okay, so we start to see this as well. And of course there are several other infections along those same lines, please.
What would be your initial blood test for just infection in general?
And so the question is, where would we look for just infection in general? Your CBC with the differential is going to be your first window. Okay, a complete blood count with the differential gives us an indication of your white blood cell count. Your white blood cell count, WBC, should be between 5 and 7. If it's elevated or low, it may be out of range, which may clue us into looking then more closely at the system. When we look at the breakdown of the white blood cells, we look at the neutrophils, the lymphocytes, the monocytes, eosinophils, and basophils. The mnemonic for us to help remember that, never let monkeys eat bananas. Okay? So, if we never let monkeys eat bananas, let me just give you a reference quickly for the ranges that those should be in percentages. 55 to 65 for the neutrophils, 25 to 35 for the lymphocytes, less than 6 for monocytes, less than 3 for eosinophils, and less than 1 for basophils. What we're looking at are the percentages of these, not the absolute level. And what we're looking for with respect to that is that percentage is optimal. When we see those percentages getting skewed, then we'll look for either an acute infection, bacterial, a chronic infection, or a viral infection. So we'll look in those areas. If those percentages are out of balance, then we're starting to look for an infection in one of those areas specifically. Okay? Eosinophils are very commonly associated with allergies, but gut infections also are a direct indication of elevated eosinophils or eosinophilia. Okay? So that's where we want to be looking. Monocytes, when it's greater than the 6, we'll start to be looking for more of a chronic infection. So the chronic Epstein-Barr virus, the chronic infection that's oral, something that's there, the pathology in the mouth. And another thing that we can find very quickly on one of these spirochetes, Helicobacter pylori, when we actually look in the body on a comprehensive metabolic panel, the protein, the albumin, and the globulin, so all of your CMPs, your comprehensive metabolic profiles, will give you protein and albumin. Okay? So your protein is your total protein, but on your lab test it'll only show your total protein and then it'll only give you albumin. Well, a total of protein means that there must be something else. So it's actually albumin plus globulin. Most of the labs won't calculate it for you now. So just take the total protein minus your albumin, and that gives you then your globulin level. Okay? Your globulin optimally should be between 2.2 and 2.8, and when it's either above or below that, it's most often an indication of the bacteria that causes ulcers and the spirochaete that causes oral pathology, Helicobacter pylori. Okay? So you actually have likely had that test already run, but it wasn't interpreted for you as such. Okay? So again, in order to have a protein total, so the protein is given, it'll just say protein or protein total, it must mean that there's an albumin plus something, and you'll only get albumin. So just take the albumin and subtract that from your globulin, or excuse me, albumin from your protein, and it'll actually give you your globulin. Does that make sense? Okay. We could make it more difficult and put an X here, right? But we won't. So that's just kind of a nutshell, if you will, from this nut. Okay. Again, once we go then from this group of potential causes, then we also want to look at the brain. Okay. Has there been a brain injury? Has there been a brain trauma? Is there a potential past brain or spinal cord injury or a trauma to some site in the body that's creating an imbalance to one side or the other of the brain? Is there something then that's created a metabolic weakness to the brain that makes it want to manifest as a weakness here that we need to bring up? Okay? Or has the body been then in one of these patterns long enough that now it's creating an imbalance in the brain? Or did this brain become dominant and now I have an overactive immune system which creates then more and more food sensitivities for me? Okay? So there are a lot of things that we have to look at when we look at why do I have chronic fatigue syndrome or why do I have fibromyalgia. Now here's the tough part of that again. Remember when you've come to the office and we've talked about the person who comes to the office and the person comes in limping, and so we're going to diagnose them with leprosy, right? Oh, that person's obviously got leprosy. Well, what caused leprosy? Oh, I sprained my ankle on the basketball court, right? Oh, I kicked my toe against the bedpost when I was changing my sheets. Oh, I had a knee surgery a month ago from a skiing accident. Oh, I wrecked on my mountain bike and hurt my hip. Oh, I was in a car accident. But every one of them were diagnosed as leprosy, right? The similar diagnoses comes with chronic fatigue syndrome and fibromyalgia. What do they have? A manifestation of symptoms that makes them look like they're limping, so therefore it must be leprosy. You've got leprosy. Take this medication. Is the medication going to help necessarily my knee pain because I've had a surgical procedure? Is it going to help my hip pain? Well, maybe. But if we didn't find or query long enough to figure out where the true imbalance is, again, it may just be leprosy. Okay? And that's where we find then these poor diagnoses get garbage canned and often become a frustrated, not only for the patient, but also for the physician. I don't know what to do with you. You got pain, you feel tired? Here, take this. If it doesn't work and you're going to come back to me in 2 months and complain anyway, get out of my office. I can't help you. And that's what starts to happen. So we get more and more frustrated until we've gone from doctor to doctor to doctor. We've tried the injections, we've tried the medicated cocktail, and we still haven't found the root to my cause of the problem. Okay? So that's really, again, our take home for tonight. I think it's always a journey. It's always a fascination when we can figure out where this imbalance is, make the corrections, and then give the person a tool for freedom again. Okay? And that's really what we look for in our office. Any questions from there? Hugh?
I was just wondering, you mentioned that one of the causes was, this could be having a surgery or some sort of trauma or injury.
Yes.
So if you determined that was the cause, how would you treat that?
Great question. So yeah, I didn't put that back up here, did I? So trauma injuries, reflex sympathetic dystrophy. When we find that, what we really need to do is find out how to break the cycle of the pain pattern. So if it's a specific pattern that we can actually either make a proprioceptive correction, meaning what's the real feeling you're feeling here? When I pull your finger or I pull on the toe or adjust the foot, that adjustment is going to summate the proprioceptors to the brain faster than the pain. Here's a really fascinating thing that we didn't even talk about. Why is it that most people feel more pain at night when they're trying to sleep than they do during the day when they're awake and alert and active? That doesn't make sense.
Is everywhere else, and that gets shut down, and they have more nerve cells available to interpret that.
Okay, so the answer from Barb is because of the way that they're dedicating their brain to the amount of focus or attention that they have. And yes, a portion of the answer is just that. Another portion is that the brain, in essence, receives all information through the spine, and the fastest tracts are in the posterior portion of the spine. Okay, we have two proprioceptive, dedicated, long tracts of nerves that are going to the brain that receive fast information. Okay, it's called the two-point discrimination and the proprioceptive stimulation associated then with two specific tracts called Fasiculus, cuneatus, and the Fasiculus gracilis. Okay?
Bless you.
Thank you. Gracias. When we look at this, the Fasiculus gracilis is everything below T6. The lower body is all the information racing up on the highway of Fasiculus gracilis. Fasiculus cuneatus is everything above T6, so the middle of the back, everything upwards from there that's summating to brain, and the perception of brain in those fast tracks. Pain, though, actually comes in anterior tracks that cross over and come up to the brain in the front, and these tracks are like dirt roads. The information on the rate of firing back to brain is very slow. Okay? So this would be comparable to a little single lane dirt road with this little old farm truck driving down that road, getting the information to the brain. Whereas the two fasciculi are actually multi-level freeways racing their little hot rods as fast as they can to get the information to the brain. Okay? So there are more pathways dedicated to that information because I have to be aware where my body is in space when I'm moving. As soon as I lay down and I'm still, though I'm not moving, I'm giving that proprioceptive feedback through those posterior columns, and consequently now the little dirt road just kept moving right along. And all night long he just keeps on driving. Okay? So